Now, I've presented on value-based care and kidney care numerous times in the past. In fact, I did a 20-minute lecture, a proper lecture, on CMS's new kidney care models, essentially where Medicare lays out their incentive structures and how they're going to pay for value-based care and kidney care in the future. But what does value-based care look like clinically at the actual point of care? Now, to be honest, in my current part-time clinical role, I'm not in a value-based medicine contract. But I generally know the goals of it, and I can tell you how to make it happen. This will be advantageous to you if you're an administrator, a doctor, a technology company wanting to come into the space, or even if you're a patient wanting to know what they should expect for good, adequate care. On today's episode, my checklist for value-based care in kidney care. What's up, San Antonio and world? I'm Dr. Qasim Butt and I'm a kidney doctor, and I'm here to break down health in a simple way. Now, what does value-based medicine look like in kidney care at the actual point of care? Well, let's start off real simple with the first thing you should be doing. The first thing you should be doing is early detection of kidney disease. Let me repeat this, all right? Good kidney care starts with good primary care, okay? So good kidney care starts with good primary care. All right, what that means is at the primary care level, we need to be testing and making sure that we detect and screen for people with kidney disease. This starts out with really basic, simple tests, some blood tests and some urine tests. The blood tests include serum creatinine and an eGFR calculation, which is roughly the percentage of kidney function. All right. As far as the urine tests, you're going to screen for things like microalbuminuria, proteinuria, and albuminuria. Next up is referral to a nephrologist early in the kidney disease process. What does that mean? That means getting them in at chronic kidney disease stage 3A or 3B, typically when the kidney function goes below, say, 60%. Now, the problem we have in kidney care as a whole is that we typically get these patients really late, meaning we don't get the referral from the primary care doctor until probably chronic kidney disease stage 4 or even 5, where the only option we have is to talk about things like dialysis. So we really can't help that patient in any meaningful way. Next, slow down the progression of kidney disease. Now, this is the biggest trend in kidney care as a whole, meaning for the longest time, we've concentrated on people on dialysis or towards that end stage of kidney care, where care is already really expensive. Now what we're doing, instead of dealing with it at CKD stage 5 or dialysis, we're going upstream, higher up to stage 4, stage 3, and even stage 2 to some degree. All right, so we're going upstream to prevent that decline of kidney function. Meaning, over the years, we don't want to see the kidney function do this. We kind of want to help it level off and stay at, say, 30–40% over time and delay dialysis as long as possible. Now, how do we do that? Well, a lot of it is diet and lifestyle modification. Now, I can sit here ad nauseum and just go over all the diet and lifestyle modification you should make. I can do a whole video on that alone. But generally, we need more interventions in the lifestyle space, but also in the diet arena, okay? Now, what's interesting is with kidney disease, at different phases of kidney function, you need different diets, okay? Meaning, you may, at a later stage of kidney disease, you may have to restrict things like potassium and phosphorus, which is an intervention that's so crucial for these patients. Now, the biggest diet modification I think would add the most value for the buck is a diet modification that helps with glycemic control or blood sugar control, meaning a diabetic diet. Now, the two biggest causes of kidney disease in this country are diabetes and high blood pressure. They account for about 70% of all the cause of kidney disease in this country. Now, so in order for us to actually make an impact in kidney care and slow down that kidney disease progression, we need better diabetic control and better control of high blood pressure. All right, let's talk about high blood pressure first. The best control we want to achieve is a systolic blood pressure of, say, 120, and the bottom number is the diastolic blood pressure of, say, 70 to 80. That's the ideal control. And how do we get there? Through medications called ACEs or ARBs. An ACE is a medication that ends in pril. An ARB, ARB, is a medication that ends in artin, okay? It's either or. It's one or the other you put on board. And what this does is it decreases the amount of protein in the urine that you'll see, but also slows down the progression of kidney disease and kind of helps level it off. Now, the other is adequate blood sugar control. We want their HbA1cs, if you know about that number, we want it at 7 or less, depending on the individual person and how they're doing, but generally around that range. Now, how do we get there? Through different diabetic managements, you may need to refer to endocrinologists, but now the standard of care for a nephrologist is to add a medication, a diabetic medication called an SGLT2 inhibitor, okay? These are really interesting medications because they actually make you pee out a little bit of sugar, but again, like an ACE or an ARB, they help level off that kidney function and keep it going over time. So in my opinion, every patient, if they can tolerate it, be on either an ACE or an ARB, and also an SGLT2 inhibitor. One of the most expensive aspects of kidney care are hospitalizations. So the other goal of value-based care is to actually decrease the amount of hospitalizations, right? Now, these patients can go in for various reasons. I want you to keep in mind, people with kidney disease likely will die of heart disease, okay? So you have to remember that. Now, one of the biggest causes of hospitalizations in this population, whether they be chronic kidney disease or on dialysis, is fluid overload or a congestive heart failure exacerbation, where they develop shortness of breath because of fluid in their lungs, or they develop swelling in their legs. Okay, so interventions that help alleviate that, whether it be better diuretics or fluid pills that we give, or more closer follow-up in doctor's offices. Anything that prevents that fluid overload event from happening can definitely decrease hospitalizations. Not to mention all the other causes of hospitalizations, but I'll start with just that one. Assist with medication reconciliation and prevent polypharmacy. Okay, so our patients are complicated, okay? A lot of them are on 5, 10, 15 medications. Now I want you to imagine yourself trying to manage those medications every day. All right. Some of these medications have to be taken once a day, some twice a day, sometimes even 3 times a day. So the management of these medications is so difficult, and these oftentimes result in polypharmacy. Now, one of the biggest places that polypharmacy can occur is the post-hospitalization follow-up. Okay. Well, let's put it this way. Every patient, when they get to go to a hospital, they have all their medications redone. And they get this list called a MedRec form at the end where the hospital says, "These are your new meds." The problem we have is it provides a lot of confusion for these patients, okay? Meaning some of them are like, do I continue this one and not continue the one at home, or do I continue both, or stop one, stop the other? So there's a lot of problems there. This is where a post-discharge follow-up from a hospital will be so beneficial to actually help manage those medications. I myself, when I've ever in doubt with the patient, I actually ask them to bring their physical bottles in and tell me exactly how they're taking them to help sort them out. This is where a pharmacy consult may be very beneficial as well to help explain that to patients and maybe set up a pill box for these patients. Education of patients. This is something I'm really kind of passionate about. That's why I do these kind of videos where I educate patients. But at the same time, the education of the patient about their disease process, where they know key terms of what chronic kidney disease is, what end-stage renal disease is, what GFR is or creatinine is so crucial for their conceptual understanding of what's going on with them. So that's one aspect of it. But the big aspect of education that we need to really emphasize is when the kidney function gets below 30%. Okay, when it gets below 30%, that's where you need to have these discussions about what's the next therapy, what's in line, right? Is it dialysis? Is it kidney transplant? Is it conservative measures, right? Dialysis can be done in 3 different forms: in center, where you go away from your house, and there's 2 options: peritoneal dialysis and home hemodialysis, where you can do it at home. But those discussions need to happen with proper home dialysis education. All right. Now, as far as kidney transplant, you need to make sure they are aware of kidney transplant, right? Get that referral in early. There are so many patients on dialysis that haven't been referred for a transplant center for whatever reason, and that needs to be done early as well. Now, lastly, conservative measures. Now, this is something where I get really kind of passionate about, because I don't think we have this discussion enough, right? Advanced directives. Grandma, what do you want at this phase of your life? You're 75 years old, right? Establish advanced directives, establish what these patients want. Get out of the mindset of doing more, but doing better, right? So what that means is, are we wanting to prolong life, or are we just going to be prolonging suffering? So that talk has to be made. And quite honestly, oftentimes it can't be done just with the patient itself. Sometimes you have to get family members involved, spouses, siblings, kids, all that, and have that group discussion with that patient. Decreasing crashing into dialysis. So what is crashing into dialysis? Crashing into dialysis is essentially everything I just discussed, the patient, none of that happened, right? So it essentially means there was no follow-up, the patient never knew or barely knew at all, and winds up showing up in an ER when they start to have symptoms and is told by an ER doctor, hey man, your kidneys aren't working anymore. We have to put this tube down your neck, into your neck vein, and perform dialysis to save your life. And that's how about 30 to 40% of patients in America get introduced to dialysis, okay? Now, the way you do this is early education, as we talked about, discussing dialysis options, getting in patients earlier into the doctor's office, but also discussing the options of dialysis early and getting accesses in their arms, okay? Now, I don't want to go over the details of that, but there's different forms of dialysis access, mostly known as fistulas and grafts. The ideal scenario is when their kidney function gets below 30%, maybe closer to 20%. You get that dialysis access in their arm and have it ready and have close follow-up. Then when the patient starts to have symptoms, instead of them going to the hospital, they're being seen by the nephrologist, and they just call, and then on their terms, on the patient's terms, you get to initiate dialysis in the outpatient setting in the center comfortably on their terms of how they want it. Increasing home dialysis rates. So one of the biggest trends, again, in dialysis as a whole is the push towards more home dialysis. And the reason being, they have better outcomes. These patients typically live longer and do better than patients that go to the center or in the outpatient setting. Now, how do you do this? How do you increase home rates, right? Some of the goals are kind of lofty at this point, what CMS wants to do. But I generally do think we underutilize the population that we have, and we kind of have a selection bias as to who we pick to do home dialysis, meaning we pick the highly intelligent or highly involved and say, this person can do home dialysis. But quite honestly, I've gotten patients that you wouldn't think to do home dialysis to do it. And this is where I think you not only have to be a doctor where you're explaining something. This is where I think you have to be a salesman for it, right? You have to sell home dialysis, and you have to push, and your whole clinical care team has to push to encourage that patient to actually do it. I myself oftentimes say, you know, if I were to do dialysis, this is the type I would do. I would do it at home. I would do peritoneal dialysis. And I explain the reason why, just to have that camaraderie or just that understanding that, hey, this is what I would do. More referrals to kidney transplant centers. The reason why they're doing this is because people who get kidney transplants typically live longer than those that do dialysis. It's cheaper, less costly than, say, doing dialysis. It's a better outcome for the patient. The patient has their life back. When you actually see someone get a kidney transplant, it's remarkable. I consider it like the giving birth to children part of kidney care. It's such a great sight to see when a patient actually starts to make urine. Now, the thing is, we need more adequate referrals, more often for referrals to transplant centers. Now, you would be surprised when you go to a dialysis unit how many patients haven't been referred or refused outright for some unknown reason. But they need to get that referral in as soon as possible. And anyone on dialysis technically qualifies, okay? Now, they do have to be a good candidate, okay? But oftentimes we want to make sure if they were disqualified, why they were disqualified. Are those disqualifications adjustable or reapproachable later on when, say, the person has a better condition? Now, the other component to this is what we call the preemptive transplant, okay? The preemptive transplant is not when someone's already on dialysis. It's before they even get on, okay? So this is when you as a doctor, nephrologist, you're actively involved. You look at the kidney function, it goes, as soon as it hits 20%, you're like, hey, I need to make this referral for a kidney transplant evaluation, okay? The reason why is typically dialysis is initiated around 15% or less, sometimes, sometimes a lot less, but around 15% is where the general consensus is. But if you get that person in early, instead of, and they get on the waiting list early, or if they have a living donor, they have an actual living donor that will donate that kidney, they can actually beat dialysis, meaning they can get the kidney transplant ahead of time without ever requiring dialysis. And this is one of the biggest goals of CMS right now, is to get those preemptive transplants in order and get these patients never seeing dialysis. Now, that's just my take on how you would best implement value-based medicine in kidney care at the actual point of care, but I would love to hear your ideas, right? What do you think of what I said? Do you have any better ideas or other ideas that you would add to this list? Please leave comments in the comment section below. And remember, it's your kidneys, your health.